Healthy lady who had an abnormal mammogram that led to a positive biopsy that led to a lumpectomy surgery with Dr. Hansen on 4/14, correct?
Yes.
This surgery showed a 4 millimeter grade 3. Are you tuning me out?
No.
No. Invasive ductal carcinoma. That's the diagnosis. More information about it, it's grade 3. There's only 3 grades, grade 1, grade 2, grade 3. Grade 3 is the most aggressive, grade 1 is the least aggressive. As we're sitting here now, it's gone. In addition to this, the margins are clear. The margins are negative, which means she got a lot. What did she scoop this out? 0 of 2 lymph nodes were positive. 0 were positive of 2 lymph nodes examined. Stage 1. That's the facts, right? Remember that, whatever that was, just the facts, right?
Mm-hmm.
That's the facts about what happened.
What, okay. You said there were 3 lymph nodes removed, right?
Is there 3 or 2? There were 3. Doggone it, you are correct. How's that?
Okay.
That was actually, I did that on purpose to see if you were listening. Yes, you were. You get a star. Okay. In the old days, decades and decades ago, when anybody came in with a diagnosis of breast cancer, they underwent a radical mastectomy. A radical mastectomy is where we surgically remove the breast from the body. When we do that, that has a local cure rate. A local cure rate means by removing the breast, what's the chance that I cured it right here? Local cure, 90+%. Big cure rate, big surgery. It wasn't until the late 1970s where we said, I have a young patient, she's got a teeny tiny little stage 1 cancer. Why are we doing a radical surgery on everybody? Why can't we just unzip the breast and scoop out what we don't want to be there? That became known as a lumpectomy, Ms. Palmer, where we just remove the lump. Much easier surgery, you get to keep your body. When we did that, however, in patients who have invasive cancer, invasive means it can spread. Invasive means that it has the cellular machinery necessary to know how to go to lymph nodes or to go to the lungs, the liver, the bones. It can spread. In patients who have invasive breast cancer, the cancer came back in that breast on average 30% to 40% of the time. So the cure rate dropped significantly when we just scooped out the lump instead of remove the whole breast. However, everybody wanted that prize, but everybody wanted that surgery. And nobody would doubt when you have a 4 millimeter tumor, like, look, this is the right answer. But what can we do after the lumpectomy to make this better? We looked at this in clinical trials in the 1990s and the 2000s. What can we do after a lumpectomy? Every single clinical trial, radiation therapy was the winner of that trial. And this is how it became the standard of care in the United States and frankly across the world. You choose lumpectomy, you get radiation. Why? Because after the radiation, guess what happened? You get the same cure rate as if you remove the breast from your body. Okay? So, with a little bit of work, with a little bit of work, you're going to be right there. There's 2 different options that you're eligible for. Option number 1, Option number 2. I'm going to go quickly through this one because we're not going to do this one. This is the conventional external beam radiation that treats the whole breast every day, once a day, Monday through Friday, and I would advocate for 4 weeks or 20 treatments. This is a standard of care option, and guess what? This option will get you to there. This option, no hair loss, no sickness, no nausea, no vomiting, no fatigue, no diarrhea. You're not radioactive, but you will get a temporary, mild sunburn that will go away 2 to 4 weeks after the radiation. Should be and would be, if you chose this option, no big deal. Easy breezy treatment once a day, no needles, no punctures, no surgery, no nothing. Just show up, lay down, do this, I radiate this, and you go home every day, but it's for about 4 weeks. The only setback would be, you get a little irritation of the skin. 2 to 4 weeks after I'm done, it all goes away. Okay. Our metric for measuring success later, it's going to be the same way that we got here. I'm going to check a mammogram, and it's going to be 6 months or so after the surgery. Middle of October, you should be getting another mammogram. Spoiler alert, it's going to be the diagnostic mammogram. Remember they did the first one? And they said, hey, I think I might see something. I'm going to take a closer look. And then they did a diagnostic mammogram, which is compression and an ultrasound, and the doctor was right there reading it. All of the future mammograms on this side is going to be that variety. Don't freak out when that happens because that's what we're asking them to do. This side, screening, no big deal. Okay? This is a whole lot of blah, blah, blah because I don't think we're going to do this. Any questions about this before I move on?
No.
Okay. In the late 1990s, which was almost 30 years ago, isn't that crazy? Serious, isn't that crazy? Remember Y2K? Everybody was freaking out at the, right? Remember everybody was like freaking out. Anyways, that was almost 30. Okay, this guy named Robert Kuski, he wasn't a guy. He was a very famous radiation oncologist. He's now at Mayo in Arizona. He said, look, I get it. Adding the radiation takes me from here to here. But is there ever a patient where I don't need to, nor do I want to treat the whole breast? Why can't I take these x-rays and target just an area of the breast? And what area would that be, Miss Dorothy?
Where
Where the scoop out happened. And so he was a very creative doctor, and he called this partial breast radiation. Pretty boring name. Okay? Partial breast radiation does not use the beam. The beam causes the sunburn. It uses a radioactive seed. It uses a radioactive seed. The answer on the test is iridium-192. That's the isotope. You will need to know that for the test. A tiny little seed. The seed moves through a transfer tube. The transfer tube connects to a device that Dr. Hansen is going to place into the breast cavity tomorrow. This device is about the size of your pen. Okay? And the tip of it is flat when it goes in, and then we turn the tip, and it blows up like a tiny whisk. We call this device a Savvy catheter. She puts it in your breast. One of the girls will drive you to my office right after. right down the hallway. You're gonna do a CAT scan of the breast with the catheter in. The catheter is bendable and flexible. Almost always it comes in from the lateral side. It will always be concealed under your clothes, under a bra. Okay? So it's gonna go in, you're gonna come to my office, and then the next day we're gonna start the treatment. That's gonna be, you're gonna come in with your catheter, I'm gonna connect the tube to the catheter, and this tiny little seed is gonna zip through the tube, and it's gonna enter the breast, not through the skin, but it's gonna enter the breast through this tube, and it's gonna sit here for a few minutes. Usually 6 to 9, 10 minutes. You're gonna feel absolutely nothing. The seed's gonna be in there, and it's gonna be delivering x-rays, those are my x-rays, okay? Just to the walls of the cavity where we scoop the tumor out. Just this part. Everything else does not get treated. You're just laying there. Time is up, 6, 7, 8, 10 minutes. Seed comes out. We come into the room, we disconnect the tube, my nurse comes in, she'll bandage it up. Have a great day. Come back 4 to 6 hours later, we're gonna do it again. 8, 9, 10, 11 o'clock, 12, 1, 2, 3 o'clock, 4 to 6 hours apart.
Okay.
In the old days, mid-1990s, everybody got 10 treatments over 5 days. 5 days, not 4 weeks. There have been modernization of this technique, and now oftentimes we do 8 treatments in 4 days. Occasionally, and I'm gonna pray, we can even do 3 treatments in 2 days.
Ooh.
Wouldn't that be nice? 2 days. Catheter goes in, do a treatment, the next day we do 2 treatments, it's coming out the next day. I'm gonna hope, I tell you what, let's emotionally and psychologically prepare for 4 days of treatment. If it's God's will, it's gonna be a couple of days. How's that? It has nothing to do with your cancer, because we already know it. It has to do with how the catheter goes into the breast. Do I have room between the catheter and the skin? Do I have room between the catheter and the ribs? That, how much room I have, will tell me how fast can I turn it on. Do I want the hose to be spraying full speed, or do I need to turn it down a little bit and have it just kind of come out a little bit slower? Okay? Be that as it may, I will be present for every single one of these treatments. Okay? That might cause nausea, but the treatment won't. Delayed reaction. Okay, it's early. It's early.
It took a while for me to get it.
So, what Dr. Kuski, remember Dr. Kuski was the guy who invented this, what he found out is that there's certain pathologic characteristics. But if you can meet all of these, you can do this. And if you meet all of this, a short number of days of treatment to part of the breast gives you the same exact cure rate as weeks of treatment to the whole breast. There's nothing wrong with this. I do this every day. But if you qualify, if you're in this box, if you're in this group, this doesn't give you any extra benefit. If you cannot satisfy these criteria, then we shouldn't be over here. We shouldn't even be talking about this. We need to be over here because of the risk is higher. So who are these people? You have to be greater than 40 years old. Barely. Unifocal, meaning just one spot. Yep. A one spot has to be less than or equal to 3 centimeters. That's no problem. You are 4 millimeters. The lymph nodes have to be checked, and they have to be negative. There can't be any lymph vascular invasion. And the important thing is the margins have to be clear. That's why we checked all those pieces of information. Okay, so if you want to, you can do this. I won't know until tomorrow. Okay? But yeah, we can do that if you want to. And Dr. Hansen knows this. She's super smart. She already knows this.
She
She already knows this. So that's why she already coordinated with my office. Hey, I have this patient. I want her to get the catheter. Get her assimilated into your schedule. And I said, all right. She's phenomenal. She does really good work, but don't tell her that, okay? Don't tell her that. Okay. So I will be present. At the end of the 4 or 2 days, I will, right here, remove the catheter. Comes right out, and guess what? Bandage. No stitches, no sutures, no surgery, just bandage. Takes about 2 weeks, and it'll heal from the inside out. Little scab will form, scab will fall off. You live happily ever after. We're going to get another mammogram 6 months from then, and we're done. Thoughts? End of presentation. Thoughts, questions, concerns?
That sounds good.
The same, no side effects. In fact, 70-80% do not get a sunburn. No hair loss, no sickness, no nausea. You're never radioactive. You don't have to take precautions. It's not going to affect your immune system. It's not going to affect your blood counts. None of that.
Only concern I have is I've been having a little trouble with my blood pressure.
Well, I can't imagine why. You're at the doctor's office, you're having surgery, they told you you have breast cancer, now you gotta talk with me, and I'm telling you we need to do radiation. Like, your blood pressure's up? Really? I never saw that coming. After this is over, guess what's gonna go back to normal? Your blood pressure.
Yeah.
Okay. So we're gonna monitor it, but that's real. That just means you're human and you're going through something and there's a little bit of stress going on right now. But you know what? After tomorrow, she'll put the catheter in, and you'll be a little bit, then you put the catheter in, you'll go, okay, that's no big deal. And then you'll be a little bit of stress about, hey, what about this radiation? Then we'll do one, you're going to go like, that was easy. And then you're going to get stressed about me taking out. And then I'll take it out, and you're going to go, that was easy. And then it's going to be over.
Yeah. That's exactly.
There is a real possibility that by Friday, May 12th, this catheter's out and over. A real possibility. Okay? So let's say some prayers tonight for that. Okay?
Okay.
Thoughts, questions, concerns? Anything from the from your support group here?
No,
Robin,
I thought Dr. Hanson was on top of it. You got her beat.
No, do not tell her that. Ever.
I won't tell her.
Please don't tell her that. I think she
don't need to know.
She's honestly,
your secret is safe with us.
So I work with, I don't know, maybe 10 breast surgeons throughout DFW. Okay, because not everybody does this. She would be considered to be the doctor's doctor. If that makes sense.
Yeah.
Yes.
Okay. So I'm definitely the weak link on your team. Okay, so I will be present along every step of the way, but I just want to see if there's any questions or concerns. I'm going to ask my director, her name is Shannon. She's going to pop in here, introduce herself. She's going to be your point of contact. Shannon Pickard. She's going to give you her card. It has her email address on it. Has her to her desk phone number. None of this front desk stuff. Leave them to her desk. Okay? She's going to be your point of contact. If you go home, over lunch, you talk about it, you pray about, oh, we forgot to ask about this, or what about this happens, what about, okay, get to Shannon's show. Shannon will also be the one that will coordinate everything between my office and Dr. Hanson's office. You're not going to have to do that. It's probably already done, and you and I are the last to know. I guarantee you, your calendar is already populated. Okay? And you and I are just like, oh, what's the schedule? And I'm like, oh, here it is, it's already done. So she's going to come in here and share that with you, okay?
Okay.
It's lovely to meet you.
Nice meeting you.
All right, we'll take good care of you. All right,
Nice
nice to meet you. And it's Tina, right?
Nice yes,
All right,
nice
good to
meeting
meet
you.
All right, give me a moment. I'm going to ask her to come in and introduce herself, and we'll get you on your way. Okay?
Thank
Have a
you.
good day, ladies.
Thank you. He's good. You went through a lot, didn't you? For nothing.